Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity. Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity.
Hello, everyone, and very nice to see all of this gathering today. It's a very special webinar because we are joining critical care, pediatric critical care physician and the pediatric nephrologist at the same time. And today we are focusing on very pivotal topic, which is AKI and different dialysis modalities and the PICU, including intermittent HD and slow continuous therapy. And we have great speakers, panelists, moderators from all over the world. We have Dr. Devonshini Reddy from South Africa. We'll talk about AKI in resource-limited settings. We have Dr. Amrit Korblani from Canada and Dr. Shagan Ersen from South Africa, who will give us a very informative dialogue and session how to best manage and improve outcome of our patients with AKI. We have our great panelist, Professor Rob Shrina from Cleveland, Ohio. And we have also Professor Khaled Al-Hassan, who is a pediatric nephrology professor and also the president of the Saudi Society of Nephrology and Renal Transplantation. Just some housekeeping stuff here. If you want to see the transcription, so everything we are saying, it can show up on your screen. You can click on show caption option. There is different languages here, so you can activate whatever language you want. Then you will be able to see everything written, transcribed on the screen. The next thing is the webinar recording should be available tomorrow, will be sent to you tomorrow. And all of our attendees today should receive their attendance certificate by next week. Also, next week will be very special to us because we have our first virtual CRRT workshop for 2 days. So it will be on November 18 and 19. So it will be on Tuesday and Wednesday. So if you haven't done yet, please register and attend. It's 2 days, 12 hours of education and evaluation and assessment with visual audios and demonstration, live real case scenarios. And also we have the American Association of Continuing Medical Education accreditation. So it will be very informative. And our panel of expertise are from all over the world, from United States, United Kingdom, from Canada, Sweden, from Europe, from India, Bangladesh, Egypt, Saudi Arabia, and South Africa as well. And we have applicants from 42 countries. So it would be very, very informative. 12 hours of intense CRRT training from A to Z will be focusing on CRRT prescription, principal foundation, troubleshooting, CRRT settings, advanced application of AI, and application of the online simulators in CRRT. Our applicants will be able to master the CRRT and to understand the core principle of the CRRT management. They are going to learn to set up, troubleshoot, and optimize the CRRT outcomes and care, explore novel CRRT technologies and clinical application. And also, not only that, but we are going to focus on fluid assessment, hemodynamic monitoring, fluid balance, and ultrafiltration. And we are going to try to help our applicants to apply this knowledge in simulation and real-world scenarios to improve their patients' outcome, their standard of care, and their clinical practice. If you haven't applied yet, please go ahead because the door for application is going to be closed on Saturday, November 15th. We are aiming to make the CRRT practice and the training straightforward, easy, and to avoid any intensity. And when they call you for a patient who might need CRRT, you shouldn't be panicked because it should be a piece of cake, should be a straightforward process, and it shouldn't be a big deal. So here is our today's agenda. Very eminent speaker will start with the first presentation by Dr. Reddy. She will give us about 15-minute very essential topic, which is AKI in resource-limited setting. Then we are going to have a dialogue between Dr. Amrit and Dr. Shigan, how to best manage our children with AKI and with different dialysis modality. Then Professor Khalid Al-Hassan and Professor Ravi Shrina are going to moderate the discussion session. So great moderators, great speakers today. And please remember that the aim of this education is not to get knowledge, but to improve your practice and to apply this knowledge into your clinical practice, because the great aim of education is not the knowledge itself, but the action. With that, I'm going to let Dr. Shigan to introduce our first speaker, Dr. Reddy.
Hi, everyone. My name is Shagan. Please ignore my background. We're just having a few technical difficulties. So I'm very happy to introduce Deveshni to everyone. She's a friend of mine, and she's a consultant pediatric nephrologist at 2 of the tertiary hospitals in Cape Town, and she's affiliated to both Stellenbosch University and the University of Cape Town. She's a pediatric representative on the South African Nephrology Association Executive Committee, and her special interests are childhood nephrotic syndrome and chronic kidney disease, especially in a low-resource setting. She does enjoy training fellows in nephrology to provide the best care possible. So Deveshni, over to you.
Good evening, everyone. My name is Deveshni Reddy, and I'm a pediatric nephrologist based at Tygerberg Hospital in Cape Town, South Africa. It's my pleasure this evening to speak to you about AKI in low-resource settings, and I'd like to thank the organizers of the webinar for inviting me to speak this evening. This is a brief outline of my talk. I'm going to cover the definition and epidemiology of acute kidney injury, along with the causes and approach to diagnosis and management, uses of kidney replacement therapy in patients with AKI, and then a brief take-home message. So, acute kidney injury is defined as a sudden, abrupt decline in kidney function, resulting in an accumulation of waste products like urea, impaired fluid balance leading to pathological fluid overload, dysregulation of acid-base balance and a metabolic acidosis, and electrolyte abnormalities, particularly of potassium and calcium. Patients in ICU have been shown to be at significant risk of developing AKI, and it's associated with an increased morbidity and mortality in these patients. The AWARE study showed that in the first week in ICU, 27% of patients developed AKI and 12% developed severe AKI. There was also an increased risk of death with the increasing stage of AKI of these patients. AKI-associated mortality has been shown to be highest in low and low-middle income countries at 18% and 22% respectively. This slide shows the causes of acute kidney injury from an anatomical point of view, including your pre-renal causes, your intrinsic or intrarenal causes, and your post-renal causes in children. This is a more practical classification of the causes of acute kidney injury, looking at the clinical setting, divided into community-acquired and hospital-acquired AKI. Community-acquired AKI is the cause of AKI that is generally seen more in low-resource settings and is usually from a single predominant insult like volume depletion from acute gastroenteritis. Hospital-acquired AKI tends to occur in patients in a critical care setting, be multifactorial, and complicates treatment and outcomes. The common causes of acute kidney injury in low-resource settings tend to be mainly community-acquired, preventable, and reversible. Causes like sepsis, dehydration, infections like malaria, leptospirosis, dengue fever, E. coli or infection-associated hemolytic uremic syndrome, not the genetic kind, and nephrotoxic herbal and traditional remedies. This slide highlights the pathophysiology of AKI, going through the 4 phases of initiation, extension, maintenance, and recovery. Just to note that the glomerular and tubular function only reach adult level by 2 to 3 years of age. Before this, changes in cardiac output, kidney perfusion pressure, changes in vascular resistance lead to an increased susceptibility to hypoxic injury. When it comes to diagnosing these patients, a good history and a thorough physical examination are essential. Ask about history of gastroenteritis, bloody stools, any drugs that have been given to the patient, presence of rashes, pharyngitis, which could be a clue to a post-streptococcal glomerulonephritis, presence of fever, any arthritis or arthralgia that preceded the illness, which could point to things like IgA vasculitis or Henoch-Schönlein purpura. Physical examination should include a blood pressure, a weight, signs of dehydration or clinical signs of shock, edema, and whether there's a palpable bladder present, which could be indicative of an obstructive uropathy. Lab investigations done should include a full blood count together with a smear, creatinine, urea, and electrolyte measurements, and a urine analysis to look for casts. Imaging of the KUB tract with ultrasound, if that one has that available. Biomarkers measured in the urine and the serum, if those are available, which they aren't in most low-resource settings, and a renal biopsy. Biopsies are not routinely performed in ICU patients, as these patients are very high risk, and the risk of doing the biopsy and the patient bleeding and becoming quite unstable needs to be weighed against the benefit of what the biopsy will show you. Biopsies may be indicated if they could change the management of the patient, for example, showing an interstitial nephritis picture versus glomerular disease. The KDIGO guidelines describe the staging of AKI according to 3 stages based on the measurement of the serum creatinine and the urine output as the biomarkers. This is the most widely used classification of AKI throughout the world. The elevation of biomarkers is associated with an increased mortality, length of ICU stay, and a need for kidney replacement therapy. Serum creatinine is not a great biomarker as it rises late, is influenced by muscle mass, fluid balance, and medication given to the patient, and most patients won't have a baseline value preceding their acute illness. Urine output is also influenced by the hydration status of the patient and the use of diuretics. NGAL is measured in urine and serum and has an 83% sensitivity and 89% specificity for tubular injury. But like I mentioned previously, it's not available in most low-resource settings. Tubular injury. When talking about prevention and early recognition of AKI, healthcare provider education at all levels, especially at a primary healthcare level, is imperative. These are often the healthcare workers that will first see the patient. Risk factor identification in these patients, those who are critically ill, those who've had nephrotoxin exposure, and those who've had severe diarrhea presenting with clinical signs of shock. Close clinical monitoring includes fluid intake and urine output monitoring, daily weights of the patient to get an idea about fluid balance on a day-to-day basis, blood pressure measurement, and clinical signs of fluid overload like a big liver or a displaced apex beat. Avoidance of nephrotoxic drugs is crucial at this stage. The Renal Angina Index, which is a scoring tool used to predict severe AKI 72 hours post-ICU admission using clinical and demographic information from the first 12 hours of ICU admission, along with NGAL, has been shown in this paper by Stuart Goldstein to be very useful. When we look at the management of AKI, the most important thing is to identify and treat the underlying cause. Ensure hemodynamic stability with fluid resuscitation or restriction, and initiate early inotropic support. Many patients in ICU will have endothelial dysfunction, leading to a higher risk of fluid overload and pathological fluid accumulation. Use of the surviving sepsis guidelines for cautious fluid boluses is definitely recommended in these patients. Correct electrolyte imbalances medically. Discontinue any nephrotoxic agents like aminoglycosides, non-steroidals, if this is feasible. Else, monitor the drug levels quite closely and adjust doses according to the estimated GFR of the patient. In a lot of low resource settings, the access to drug level monitoring is not possible, and it is better to actually stop nephrotoxic agents as far as possible. Using diuretics for fluid overload can be useful if one doesn't have access to kidney replacement therapy, because any amount of urine that the patient does pass will assist you in your management of them from a fluid balance point of view. If the cause is intrinsic AKI, be sure to treat the infection or the inflammatory process. Indications for kidney replacement therapy in severe AKI are when the patient is on maximal medical therapy and still has electrolyte imbalances of potassium, calcium, and phosphate, fluid overload, which is the common indication due to the increased mortality risk, and meta-analyses have showed a 6% increase in odds of mortality for every 1% increase in fluid overload, significant acid-base dysregulation, and signs of uremic encephalopathy. To talk about types of kidney replacement therapy, peritoneal dialysis in particular is preferred in low resource settings. It is less expensive and technically easier to administer. It uses the peritoneal membrane for diffusion. It doesn't require central venous access or anticoagulation. It's generally safe even in critically ill patients because it doesn't result in rapid fluid shifts. The PD catheter can be inserted by non-nephrologists and non-surgeons. One can improvise with catheters and make one's own PD fluid if commercial fluid is unavailable. Things like nasogastric tubes with extra holes placed, intercostal drains, hemodialysis catheters have all been used as substitute for PD catheters when Tenkov catheters are not available. This paper, which was recently published in Pediatric Nephrology, describes a cohort of patients in whom hemodialysis catheters were used to initiate PD in Senegal. And this is because hemodialysis catheters were freely available to patients, but there was a shortage of Tenkov catheters. Continuous flow peritoneal dialysis using 2 catheters has been shown to improve ultrafiltration and clearance when conventional PD is not enough, as shown in this paper by Peter Norse et al. Contraindications to PD are certain intra-abdominal conditions and the patient having an open abdomen. One needs to be aware about possible respiratory compromise during the full and dwell phases of PD, especially for those patients on mechanical ventilation and oscillators. Complications of PD include catheter leaks, obstruction, and peritonitis. An excellent reference to read about PD are the ISPD guidelines for PD in AKI. These give you guidelines about alternative catheters that can be used, as well as ways to make up your own PD fluid, complications, and how to manage these as well. In terms of extracorporeal methods, which use diffusion and convection for adequate clearance, intermittent HD, SLED, CRRT, which is actually preferred in hemodynamically unstable patients, which are most frequently ICU patients, are all used. These methods are expensive. They require specialized machines and highly skilled technologists to set up. They require central venous access, which is not easy in small babies, which is high risk in coagulopathic patients who are septic in the ICU, and use of anticoagulation to prevent clotting of the circuits. In terms of the challenges for managing acute kidney injury in low resource settings, one of the main challenges is healthcare system limitations, a lack of access to kidney replacement therapy, laboratory investigations like serum creatinines, drug level monitoring, lack of imaging availability, a shortage of skilled staff including nephrologists, dietitians, nurses, social workers, psychologists, shortage of medication to treat common conditions. Geographical limits include lack of transport from rural areas to bigger centers where there are ICUs and emergency rooms equipped to treat children. Financial restraints, especially in countries where parents themselves are required to pay out of pocket for kidney replacement therapy for their children. Cultural barriers to managing AKI, such as the use of traditional and herbal remedies to treat common childhood illnesses. A PD first policy is taught in the Saving Young Lives program to be implemented in low resource settings. So use PD above all else. When looking at outcomes after an episode of acute kidney injury in critically ill children is associated with a longer ICU stay, prolonged mechanical ventilation, and is an independent risk factor for in-hospital mortality. Longer-term AKI survivors have been shown to be more at risk of repeat episodes of AKI and long-term risk of CKD with proteinuria and hypertension. Follow-up of these patients is therefore crucial in the long term. The take-home message from my talk is that AKI is associated with a significant morbidity and mortality in PICU populations and especially in low-resource settings. Good outcome for these patients is highly dependent on early recognition and appropriate timely management. Follow-up post-AKI is crucial. The focus in low-resource settings needs to start with improving education and the early recognition of high-risk patients, and implementing a PD-first policy for kidney replacement therapy in these low-resource settings. Thank you.
Thank you so much, Dr. Reddy, for this very nice presentation. And again, I'm emphasizing that if you want to see the translation or the transcription, you can click on the show caption option or tab in the lower part of the screen. Then you can choose whatever language you want to see the transcription with. Our next two presenters will have a very nice dialogue between Dr. Amrit Karbulani and Dr. Shagan Ersen. Both are from Canada now. Dr. Shagan is originally from South Africa, but just moved recently to Canada. So they are both very smart, and they are going to show us how we can use the technologies and the simulations and AI, online calculators and apps in the CRRT and also in HD.
Well, thank you so much for that introduction. I don't know how smart we are. Shagan came to Canada in the winter, so maybe that speaks volumes. But we're excited to talk about this topic. So let's jump right in the interests of time, and talk about dialysis in the ICU. So Shagan, let me ask you about a kind of a typical case that we might see, right? The 1-month-old who comes in, diarrhea, changing diapers all day, there's nothing coming out. We see them, they're not quite themselves. They're lethargic, tachypnic. You see this kid in the hospital, they're tachycardic, you can't even get a measurable blood pressure yet, and you see those clinical signs of dehydration. So that typical baby who's got something going on and they look quite dry. So my question to you is, how do you manage the fluid prescription in this baby? How do you assess the AKI, and how would you deliver dialysis if needed?
Amazing, Amrit. Thank you. I think this is a case which can be terrifying, but I think is highly rewarding if you manage appropriately. So let's just start on the fluids. So the fluid prescription. So the discussion is always about Ringer's lactate and 0.9% saline. So I put this here because we've just had a talk on low and middle income settings. So firstly, depending on what you have, if you have one available, use that, as we need to get this child out of shock. And the discussion here comes with an isotonic fluid versus something that is hypertonic, with saline having 154 millimoles of sodium. Are you going to contribute to that normal anion gap acidosis? So these are concepts that we just need to process in our patient, but the ultimate endpoint is get that patient out of shock. And this is a case where I know guidelines are saying 10 to 20 moles per kilo of fluid. In the ICU setting, I often use 5 moles per kilo of fluid, and I'm very scared of it. But this is a case where I would advocate for larger volumes very fast, because that is what you require. And how often do you repeat? So again, if you look at surviving sepsis guidelines or APLS guidelines, they do say 3 times, but I'd go further. So importantly, this is an amazing paper that was put in Intensive Care Medicine in 2022. It is the ROSE technique. So you're resuscitating, you're optimizing, you're stabilizing, and then you're evacuating that fluid. So in the resuscitation fluid phase, you can be aggressive. And if you look on the right of the slide, there are targets, or rather endpoints, that you can look at in the ICU setting to see, do you have a response? And again, a lot of this will be POCUS-based. And then once you do, you have to look at, are you optimizing the patient and are your endpoints adequate? So that means, is your level of consciousness improving, cardiac output, renal flow, are your lactate levels stabilizing and hopefully starting to decrease? I think that's important. And once you have that patient in that phase, you're now looking at stabilizing, so maybe cutting back on fluid and then evacuating the excessive fluid provided to the patient. So importantly, just if just a bit of a busy slide, but if you look at the endpoints on the right, maybe colleagues, you can take a screenshot. I think it's a great idea to look at what those endpoints are in guiding your prescription. Slide. So as I said, I'm very scared of fluid, and I think when I was a junior doctor, I kind of just poured it into patients. I'm not thinking of what I was doing, and I'm not going to spend too much time here. But if you look at this slide again from the same journal article, it goes through each system and shows you what you are doing to your patients. And let me just focus on the kidneys, because I'm a nephrologist first before an intensivist, and you can cause interstitial edema, you can drop that venous pressures, increase renal blood flow, increase interstitial pressures, and ultimately impact your GFR on your patient. And that's just one organ. And we know that there's an independent indicator of mortality with AKI and fluid. And now when you add the rest of it, you can see how fluid can be a bit dangerous. Slide. So where do you want to go? So we've graded our AKI using our KDIGO classification. Some people may use AKIN or rifle still. We admitted the patient, and I'm going to touch on this briefly, and this was taken from Saving Young Lives, which is run through ISN and ISPD. And if you combine your renal angina index, and it's a severity score based on fluid status in the first 24 hours, and whether you're admitted to ICU using inotropes or were you a bone marrow transplant, and you derive a score. And if you're more than 8, that is predictive of severe AKI at a stage 2 or 3. And if you go further onto the black box, combining this with a biomarker, it can guide you in terms of starting renal replacement therapy. But I still think there's a clinical side to this as well, where you need to evaluate your patient at the bedside to make this decision. Slide. Thank you. I'm not going to spend too much time on this one, and we're going to, if the next slide comes up also on indications, we might skip it for the sake of time. But these are the common indications that we all know clinically, looking at uremic signs, being fluid overloaded, having a metabolic acidosis or a significant hyperkalemia. And I think the key word is you're just refractory to what your medical interventions are. So KRT in itself is not great to start off with. Make sure you optimize your medical therapy. Now we're choosing our modality, and this is a very brief and simple diagram that I created. We're looking at acute forms of kidney replacement therapy, obviously not transplant, and you'll decide, are you either using hemo or PD? And there are various ways you can then prescribe this to the patient. So I'm going to leave CRRT to you, and I'm just going to focus on PD. So PD can be done either manually, and it is so easy. And this is one of my patients who weighed 550 grams that I ran peritoneal dialysis on. It worked brilliantly. It can be done on patients if your indications are correct and if you have a team to support you. So there's no reason to be scared of it, and initiating it, give a patient a chance. Slide. So choosing PD, there's a large surface area, and therefore you can improve your clearance. It's dynamic and more physiological. There's less inflammation that is postulated, and there's a better cardiovascular tolerance. And this, again, there are a lot of caveats on this, but overall, and if I use a brushstroke statement, it is something that you can employ in patients if you've chosen them correctly. Slide. I put this here quickly because often I've gotten many questions from colleagues around South Africa saying, I have a patient who I feel needs dialysis. I cannot get them to a kidney unit. What do I do? So these are the ISPD guidelines that have been published. They are being updated. It was with Peter Norris and a whole team, and every step is prescribed to you. It even touches on continuous flow peritoneal dialysis, which is still used more in the research areas, but the guidelines are there. They are easy to understand, and picking up the phone means any one of us can help you. I've helped colleagues telephonically to initiate peritoneal dialysis. Slide. So improvised dialysis lines, and again, I took this from a slide from Saving Young Lives, and in light of Deveshni's talk, and lots of colleagues, especially on the African continent, have shown you do not need a specific dialysis catheter to start PD. And so this little baby that you see in front of you has a hemo line that has been inserted into the peritoneum to run peritoneal dialysis. I've done PD using a intercostal drain, and I've seen colleagues do it with nasogastric tubes. There are many papers, or rather case reports, that have been published to show you it is possible, and we can definitely save lives. Slide. So how can you make PD fluid? So we all know costs come with this, but most of us have access to this fluid, again, from saving young lives. So you can take a bag of Ringer's lactate, and if I put the electrolyte concentration there that is important in this context, and you can see it is similar to what you get from our major providers when you're getting formal fixed premixed bags. And if you spike your bag and add some dextrose, you can change your glucose concentration and rather your osmotic gradient to improve your ultrafiltrate. Obviously, this comes with the risks of introducing infection, but if you are sterile and you don't have any risks, and again, these are for our colleagues who might be in situations where you don't have access to resources, I think it's a fantastic opportunity. So combine this with a nasogastric tube, an IV giving set, a urine catheter, and a stopcock, and you're ready to go. Slide. Amrit, if you can go here. So how do you prescribe? So importantly, look at your indications. Are you targeting solute clearance in your patient? Are you looking at more fluid overload? What is your dialysate choice? So again, if you have a premixed one, you will be looking at what is your glucose concentration? What is your buffer? Are you using a bicarb or lactate buffer? What are your electrolyte concentrations there? So look at your patient and prescribe specifically to what your patient needs. And so importantly, all you need are a few times. So your in time, which is generally about half a minute for that fluid to run in if your PD catheter works well. And you leave the fluid in there on average for an hour and let it run out for 20 minutes. So you can prescribe easy times. And I say that because PD is often run by nurses. And nurses are heroes in the situation. So don't prescribe odd times for them. Give them easy times to help you with your prescription. And if there are questions in the chat, I'm happy to answer those whilst Amrit is talking in a bit. And then you can add different things to your dialysate. So you can add electrolytes specifically. For example, I've dialyzed a child with a sodium of about 210. That makes you very scared, especially when you're comparing that to a dialysate concentration of about 134. You can spike with antibiotics if your patient has developed peritonitis, and hopefully we're all great prescribers and treaters. We are not going to get that. And heparin because of the resulting inflammation to prevent that fibrin accumulation and therefore occlusion of the fenestrations on your catheter. Slide. So this is a very easy slide, and I'm trying to keep it as basic as possible. And if you look at just this diagram, this graph rather, which is titrated against ultrafiltration to time, and you can see that with a shorter amount of time, you have a spike in what your ultrafiltration is, and with the prolonged time, that is when your UF starts to drop. So that means if your patient is massively fluid overloaded, they'll probably benefit from a shorter dwell time to rapidly pull that fluid off versus a longer dwell time. So again, is my patient fluid overloaded? Do they have significant pulmonary edema? Do I need to get that off fast? Slide. And then this is compared to what you're trying to target in terms of your solute clearance. And this is, you're looking at DP ratios here, which we often do for PET tests. But because we're in an ICU setting, I'm not going to talk about that. But you can see there are different types of clearances here and looking at the molecular weights of these molecules. So I often ignore urea because it's a tiny molecule. But if you look at your bigger molecules going from creatinine upwards, and so that targets middle molecules, which aren't listed here, but they require more time to pull off. So for example, if you have a patient in our setting, well, in the setting of a low resource setting where you may not have access to intermittent hemo or CRRT, and you need to pull off certain toxins, you can try longer dwell times. So and these are rules of thumb. If they're not fixed, you need to titrate to your patient, but I hope I'm showing the difference. Short dwell time for fluid, longer dwell time for solute. Slide, Amrit. There are many ways you can do it, all right? So depending if you're doing it manually or if you're doing it with a cycler. So tidal PD is fantastic. Right at the top, that means you leave a little bit of residual volume. That does help with that inflow pain that patients can experience, especially if they're a bit more awake. Continuous flow PD, which I touched on in the ISPD guidelines. So not used as regularly, but if you look on the right, fantastic urea clearance. So your dose that you get effectively, whilst you cannot prescribe it meticulously, is effectively better than your other forms. And then if you look right at the bottom, that would be intermittent PD, which we typically use in the acute setting. So rapid in, rapid out, and rapid cycles. So no long dwells as you would do in a chronic patient, but you do get adequate solute clearance in those patients. So what are the outcomes? So this was taken from a paper which unfortunately is a bit old, and it looked at a retrospective collection of a few papers. I mean, you have Dr. Tim Bunchen at the top, who is fantastic with CRRT as well, and a few of other colleagues, and they compared what your survival outcome is. And please bear in mind, there are obviously multiple biases when you're using a retrospective paper. You don't know, are those patients all similar in terms of their baseline when you're going forward? But if I just look at the top, in terms of PD and hemofiltration, the survival was fairly comparable. In this paper here, HD did much better. But then if you go to another group of colleagues who looked at patients between a week and 11 years old, their PD and HF survival was pretty comparable. And I think the point that I'm just trying to show you is that once a patient does need KRT and you're prescribing dialysis, we know that those are severely unwell children. And when you combine it with their outcomes, your risk of mortality is fairly high, and it is definitely something you need to counsel patients on. They are great outcomes, but it is just something to keep in mind. Slide, perfect. And now, Amrit, I think we're going to be going over to you. You're going to teach us a bit about CRRT.
Absolutely.
So I'm going to throw a question at you. I had the tiny shock gastro child. So you have a 3-year-old who's 25 kilos. He's admitted in septic shock, still shocked and anuric. Sounds like the majority of our ICU patients. Unfortunately, there is 20% fluid overload rapidly into this patient's admission phase. It requires multiple vasopressors to maintain the blood pressure. Your electrolytes are a sodium of 140, a potassium of 5.8, a urea of 30, and a creatinine of 250. And so my questions for you: what would your advantage be of using CRRT over other modalities with this child? How would you manage this fluid overload? And importantly, like many of us don't do it, I'm a bit rusty right now. Can you help me? How am I going to prescribe something for this child?
Absolutely. And this is, I think, one of those cases where if you have access to CRT, which I know is a big if, I think there are a number of advantages in this case. So CRT would provide control. We're all a little bit of a control freak when it comes to medicine, and especially in nephrology, ICU, we're all control freaks. And with CRT, I know that I can get the exact amount of fluid I want within reason. Whereas with PD, and especially with the amazing kind of improvisation innovations that you demonstrated, we can usually achieve our goals. With PD, I know I can get what I want when I want it. And especially with kids with AKI, with anybody with AKI, the first thing we're always thinking about when there's fluid overload is fluid restriction. It's one thing in an adult to fluid restrict, but when we think about toddlers, infants, that really does limit nutrition. And with CRT, we do have that added advantage that we can be a bit more selective with our fluid removal, and that can allow us to implement early nutrition as well. There's also tolerance. Much like how PD can be used in hemodynamically unstable patients, we can have CRT as an advantage there over intermittent hemodialysis. With CRT, we can remove fluid slowly, we can clear slowly, which is actually advantageous for hemodynamically unstable kids. We've said many times, of course, that there's barriers to CRT, including access, but I hope with talks like this and some of the tools we're going to show you that education hopefully is not going to be one of those barriers. So when it comes to CRT, there's a number of aspects to the prescription that we think about. And obviously, in the interest of time, I don't want to go over everything for too long, but just to say that all of these components are very important. And without any of them, the prescription can suffer. Where I want to spend most of the time is talking a little bit about anticoagulation clearance and fluid removal. But things that are always very important for any extracorporeal therapy, we need good access. Like everything else, if the access isn't great, we know the therapy is doomed to fail. And both your access and filter are often chosen based on patient size. There may be specific cases where one filter might have added benefits, but for the most part, access, filter, blood flow are going to be size-based things. And when we think about our filter in particular, we do have to remember that unlike PD, there's extracorporeal blood volume here. So a bigger filter does also come with more extracorporeal volume. With any extracorporeal therapy, we always have to think about, are we ever going to have too much of our patient's blood outside their body? So we can calculate or estimate a patient's blood volume based on their weight. We usually say for most kids, it's 80 mils per kilo, maybe different for newborns or infants, maybe different for older kids. As a rule of thumb, 80 mils per kilo is often what's used. And if you look at your extracorporeal volume, when your extracorporeal volume, so the volume outside of the patient, is starting to exceed 10 or 15%, you may need to think about a blood prime as well. So that is one of the disadvantages of CRRT as opposed to PD. When it comes to anticoagulation, we know that when you go heparin-free or rather no anticoagulation, these circuits often don't last very long. And that's something that we see more in pediatrics and adults because we're using slower blood flow rates. So in adults, you may be able to get away with it sometimes, but in pediatrics, it's quite hard. I'm going to just mention epoprostenol as something that's used more nowadays in the US, those of you in Western Europe as well. But most commonly used are unfractionated heparin and citrate. Heparin is easy. We're all using heparin regularly for multiple different procedures. Whereas the problem is when you're systemically anticoagulating your patient who's already critically ill, who may require more procedures, a chest tube, a lumbar puncture, who may have a risk of bleeding to begin with, systemic anticoagulation has its drawbacks. Citrate as a regional anticoagulation does have data showing that it may actually have superiority over heparin and should be possibly considered as the first line. There was some old data saying that you shouldn't use it with liver disease, but I think even now we have better recognition that as long as you're monitoring carefully, you can use citrate even with liver disease. And citrate's binding to the calcium in your extracorporeal circuit, so that's not allowing the clotting cascade to work, and then you replace calcium to the patient. There are concerns, and citrate often does come with a price, and that can tend to be metabolic alkalosis from excessive buffer, disturbances in your calcium, your patient's ionized calcium, depending on the ratio of citrate to calcium being given. And the most concerning complication is typically accumulation of citrate or citrate toxicity, citrate lock, where your patient now has enough citrate accumulated that they are actually accumulating citrate faster than they're metabolizing it. And that's where you can run into metabolic disturbances as well. There are different modalities of CRRT. There's CDBH, where we're using primarily convective clearance, so that's solvent drag, like when you're making coffee. There's CDBHD, where we're using diffusive clearance, like our regular hemodialysis, where it's diffusion from high to low concentration when you're making tea. Or we can combine both modalities with HDF. I'm not going to spend a ton of time on this because we talked a little bit about clearance already, but just to know that convective clearance may help with some slightly bigger or slightly less small molecules. But what we know in general is that there's not a significant, no significant data to support one modality over the other. Your clearance in CRRT is going to be the additive number of whatever your dialysate rate is, whatever your convective clearance rate is, so your replacement fluids, and then any additional fluid you're removing from your patient. Remember, with convective clearance, if your machine is applying pressure to that blood to remove, let's say, a liter an hour, if you didn't replace that, your patient would get very dehydrated. So we replace the fluid that's being cleared. So our replacement fluid rate is essentially our convective clearance rate. You can give your replacement fluid pre-filter or post-filter, pre-blood pump or post-filter replacement. There is advantages and disadvantages to both. Giving it pre-blood pump may help reduce the risk of clotting, whereas post-dilution will have less of an impact on your clearance. There's no evidence, like I said, for one modality over the other, so the general approach is to try to stay consistent in your center. Many of us feel that CBHDF, so combining both, may be the easiest way because you can easily turn one off and you have the advantages of both modalities there. People learn differently. People have probably been trained differently on how to prescribe their clearance. Many people use milliliters per kilogram. Many people use liters per body surface area. So I personally use the 2 liters per 1.73 meters squared. And I think you said you use the 20 to 30 mils per kilo. I think as long as you're staying consistent, that's the most important thing. So this would be considered a standard clearance. So this is much lower in a small period of time than you would get with intermittent hemodialysis. But over the long term, you can actually achieve adequate clearance as well. And trials have found that excessive clearance has no benefits in the short term, except in specific indications like inborn errors of metabolism or intoxications. So like I said, when you think about normal kidneys or normal CRRT, in general, it's a lower clearance in a short period of time, but over the course of a week, CRRT can actually give you perhaps better clearance than intermittent hemo because patients are on it continuously around the clock. So just to give an example, these are the same bullet points I put up there earlier, but when we talk about a clearance, how do you calculate a clearance in terms of body surface area? So if an adult is 1.73 meters squared and we want to give them a 2 liter per 1.73 meters squared clearance, we would take our 2 liters and divide it between perhaps our pre-blood pump rate, our post-filter replacement, and dialysate. So here I've put half of that clearance as convection and half of that clearance as dialysis. But what about for an infant? What about for a 0.5 meters square infant? I would take my 2,000 mils per hour, divide it by 1.73 meters squared, and I'd multiply it by my patient's body surface area. So in that case, I have about 580 mils to play with, and I can divide that as I want between my convective clearance, pre-blood pump, post-filter, and dialysate. And again, there's no strong evidence for one or the other, except we really just want to have consistency. I put a note on filtration fraction here, which I won't go into detail, but just to know that there are some specific considerations around trying to maintain circuit life. And of course, happy to talk about this after if people have questions as well. But if anybody ever wants to screenshot, of course, the slide is there. And when it comes to solutions, it's always important to know what's in our solutions. Shagan did a great job talking about our PD solutions and knowing that most of your CRRT solutions will have normal sodium, variable potassium, calcium, and without replacement, you will run into hypokalemia and hypophosphatemia when somebody is on CRRT. When it comes to removing fluid, like I said with CRRT, we want to have control, but we also want to make sure we're not overdoing it. Just because we can doesn't mean the patient will necessarily benefit from excessive fluid removal. So a good rule of thumb is somewhere in the neighborhood of 1 to 2 mils per kilo per hour as a starting point, and you can adjust that accordingly based on what your patient will tolerate and how badly you need to get those fluids off. How are their lungs doing? How's their heart doing? Nephrologists, we always want to go slow and steady. Intensivists want to go fast. We kind of meet somewhere in the middle. So when we're tracking fluid removal, we really are tracking all of the fluids going in and out of that patient. So it requires great communication between nephrology, critical care, nursing, everybody. The last point I'll put up is remember, we're not just taking out the bad stuff. We're not just taking out urea and potassium and ammonia. We're also taking out medications that that patient may need, antibiotics. We're also taking out amino acids that that patient needs. So involving a pharmacist, dietitian, or at least being aware of your drug monitoring and nutrition are going to be critical. Now, we've been talking about this for a while, but I'm sure you're all sick of hearing us talk already. So why don't we actually do a bit of practice? You know, Shagan, I kind of copped out there. You asked me a question about that 25 kilo kid with septic shock who needs CRRT, and you said, how would I prescribe it? So perhaps I'll throw it back to you. I have your patient here, a 25 kilogram, 3-year-old kid with septic shock, fluid overloaded. How would you like to prescribe the CRRT? And just in the interest of time, I'd say you've got some hyperkalemia here and no real detectable liver problems that I can see.
Well, Amrit, I always think it's great to fire the question straight back. That's always a good plan.
Yeah, what do you think that means? Yeah.
So I saw your blood pressure is a bit low. The potassium is trending on the higher side. Your bicarb is low, so and your platelets are down as well. Just making me think in terms of what I'm prescribing for my patients. Am I worried about heparin, etc.? So if I go to the bottom, let's see. So for my access on the patient, let's start there. I mean, the weight of the patient is given. So let's choose the 9 French line on this patient. Okay, the filter. Yeah, so I mean, it's giving me the weight as well. I'll choose the medium filter on this patient.
Perfect. And I can tell you your extracorporeal volume is about 6% of your total blood volume right now.
Oh, fine. Okay, good. So I don't need blood. Let's see, what can I use there? I'll just try some saline. All right.
Any preference for anticoagulation?
I'll do what I do, what we have available in South Africa. Let's just put some heparin there. I know the platelets are low, but for argument's sake, we'll do heparin.
Perfect.
Solution is there. And I suppose you want to jump to the blood flow rates, right?
Sure, yeah, absolutely.
So I think total we have, if I did the math whilst you were talking, I used your formula. So I have about 1 liter to play with on this patient. Let's just put something crazy here and just see how it works, right? So I'm going to do let's make it 300, 300, 300 on the dialysate and the post filter.
Okay.
And
And what do you want your blood flow to be?
let's make it something crazy. Can I make it 100?
100. Let's do it.
And
And do you want to remove any fluid?
now I'm no longer a nephrologist. I'm an intensivist. I'd like all the fluid out immediately. Let's make it 200 mils an hour.
200 mils an hour. Ah, yeah, you said you were a nephrologist first. You lied. All right.
Yeah,
Well, let's see. Let's
let's
see
see how it
how that
goes.
goes. You know what? We ran into some issues.
Okay,
So
fine.
it looks like your target clearance might be a bit on the low side there. So you may
Okay,
be a
fine.
bit lower than your 2 liters per 1.73 meters squared. And you
Yeah.
know what? It looks like your fluid removal might have been too aggressive there, Mr. Intensivist.
So okay, so like fair enough. I think it's great. Like I'm seeing where my mistakes are. Do you just want to talk us through where would it be? What should I have?
Yeah.
What should I have
So I
done?
think you chose appropriately for your access filter and prime. I think heparin, any anticoagulation that you're comfortable here would be great. I think your blood flow was appropriate as well. When we do the math, looks like 2 liters for this patient's body surface area would be about 1,050 mils. So you were
Okay,
probably around 900 mils. Now, would that have made a big difference? Maybe not. But let's say we upped it a little bit, something like closer to a 2 liter clearance. Now,
fair.
you went big with the fluid removal, which will make you happy maybe for about 20 minutes before before your nurse starts to tell you that, hey, we've had to add 3 more pressors.
Fair,
So
fair.
this may be a case where we start with 1 to 2 mils per kilo. So I'd say maybe depending on how your lungs are doing, depending on how aggressive you need to be, maybe we could start with, 1 mil per kilo, negotiate around 2 mils per kilo.
Sure,
And
let's start easy.
if our patient's tolerating it, as they
Amazing,
are, maybe we can take it from there.
amazing.
And what do you think? Maybe we have time for a quick one here.
I think
How about this one? Everybody's favorite thing. Uh,
maybe for the sake of time, like Amrit, you can
yeah,
just talk us through it. And whilst you're just going
yeah.
down, just for our attendees, I see if you look in the chat, the access to these simulators, and I'm going to punt Amrit here. I do it far too often. He has created these simulators. They are open access and they are free. Importantly, you can use them wherever you want. It teaches you how to do it, and just give it a go. They are in the chat at the moment. I hope. Yes, they are. So please take a look and let's see how it goes.
Perfect. And I will, in the interest of time, let people play with it as well. We can also practice our alarms. So there's the alarm simulator as well, because there's nothing more exciting than getting called about alarms beeping on the machine. So
So
maybe
which
I will leave
alarm
it
would you worry
there.
about? Which alarm would you worry about?
You know what? The one that I think always gets me is that low return pressure alarm.
Fair enough.
That's one where I'm always getting a bit worried.
So
So
so so could that happen if the patient is kinking their leg, or if you have clots in the line, if it's an old line in your patient and you haven't been great with your anticoagulation, maybe you have some tiny clots sitting there. Could that do that here?
yeah, we usually think about the higher return pressure in that
Yeah.
case. So what I'd really be thinking about here is mainly, do I have a disconnection? So first thing first, making sure my connection to the patient is okay. That's the first thing I'll rule out. And otherwise, you can always think about adjusting your blood flow rate as needed to see if that'll help. And certainly there's no shortage of alarms when it comes to CRRT. So hopefully people can find some use in this as well.
Okay, amazing, amazing. No, thanks, Amrit. I think it'll be useful. And I'll let you just wrap up our talk.
Perfect. So, like we said, we have more cases that people, of course, can feel free to work through. Whether you want to prescribe CRT, whether you want to troubleshoot, hey, why am I not getting what I want? Why isn't the potassium dropping as it should be? Hey, how come my patient's blood pressure completely tanked as soon as I started? How come my patient's platelets have dropped the second we started CRT? And as you work through the simulator, you'll see that the cases perhaps get more and more complex and hopefully relatively realistic to any practice as well. So I will leave it there and I will turn it back to the boss.
Excellent. So thank you very much. Wonderful, especially the last part of it, the interactive, and I love the simulators. And probably also I will let our audience to know that PCRRT Iconic, they have their website, which is pcrrt.com. Most of the protocols of using the CRRT you can find in there, pcrrt.com. So thank you very much. Was wonderful going with these simulators stuff. So we'll go over now the questions. So the first question they ask, thanks a lot from Abdulrahman. Thanks a lot all the directors and contributors for WKA team with his question. So if I use another modality of the CRRT like CVVH-D or CVVH, also is there is a difference between pediatric patient and adult patient and prescription dose, and to how to appropriate in pediatric fluid selection in pediatric CRRT. So in summary, the difference between the modalities in terms of the outcomes, and probably you touch base on that, and also the other question, the difference between prescription adult and pediatrics. So either of you, Emrit, can you answer this probably?
Yeah, absolutely. So the different modalities, if you want more convective clearance or diffusive clearance, using one modality over the other. So in theory, the way my simple brain thinks about it is if there's something I need to clear that I know is cleared better with convection. So let's say, for example, in rhabdomyolysis, that perhaps myoglobin clearance will be a little better with convection. Theoretically, CVVH using purely convection would have an advantage. Let's say there's something I specifically don't want to clear. Let's say my patient's got cancer and is on a chemotherapeutic drug that's cleared more by convection. Well, that's probably a really important drug. So maybe I should prioritize diffusion so I'm not taking out that drug. Those are the ways I kind of conceptualize it. But from a big, big, big data perspective, overall outcomes don't seem to change whether you use one or the other. So if you are a small to medium-sized center, my advice, and I would love to hear what others think, is try to be consistent. As if you're consistent with your nursing staff and your team, consistency will probably be the best thing in terms of optimizing your ability to get the machine up and running. If you haven't done it in a while, if you have a nurse who hasn't done it in a while, and I think that probably would outweigh any theoretical benefits from one modality over the other.
Excellent. Yeah. So I totally agree with you.
I
And
can add something. Sorry, my voice is
Go-
very bad, so I'm not
oh,
talking. You guys can hear me well?
absolutely. Yeah, go ahead, Rabish.
Yes. Sorry, this is a forum which is not a good having intensivist and the nephrology, adult nephrology intensivist and pediatric nephrologist. First of all, for rhabdo, you always do convection and diffusion combined. You don't do plain convection. This is a speculation that you're going to remove the middle molecules. Convective theories are good in the setting of sepsis. But if you are looking for a middle molecules to be removed, you have to do hemodiafiltration both together. The other thing is modalities doesn't matter. Dose matter. Time matter. And go back and check your modalities every 3 to 4 hours. Once you put the patients on convection, which we get and go back, patient get hypophosphatemic, hypokalemic, hypocalcemic. So middle molecule theory is an hypothesis. We tried to do that study. Tim did it. It was stopped by the FDA. And we have shown removing of the dams and other protein. But if you're looking for multiple myeloma, you're looking for rhabdomyolysis where you want to click the things, you need to have a diffusive clearance with convection. Now, how much you divide is your gestalt. You can do whatever you want to do it. Second, yes, there's a huge difference between adult and peds. Dosing is different.
Completely.
Third, you need to learn how we are doing now is high flow step down. Because if you think it's an urgent matter, you need to fix the solute, go for a high flow. Go for 35 ml per kilogram per hour for 12 hours, and then you can always step down on it. So those are the things you need to realize. Convection, diffusion, and if you want to make it confusion, it is diffusion and filtration. None of the modalities have shown any superiority. What is important is the time, effluent dose, because your CRRT is different on your effluent dose. frequent assessment, and change in the modality. Those are the things you really need to keep in mind. Only thing that makes me
And
very...
Robish, probably adding to it, Robish, completely agree with you. Maybe adding to it also your nursing, adaptation of your nursing, which modality, that's play
Yes.
important role also.
And what works for your institution, do it. Don't try to be navigating in the middle of the night to adding, like in our center, we do CVV HDF, in Cleveland Clinic, we do CVVH, whatever you're comfortable, because you're going once a while, and Amr can add on it too. It's a nursing who runs the CRRT.
Yeah, I totally agree. So, yeah, totally agree with you. So don't try to push the nurses, especially overall the outcome, not much difference. You're right. I totally remember Tim Punchman and Pat Brophy, their talk as well, Robish. So it's important for you, the nurses, if their adaptations. So very difficult to change from one to another. So another question is from Saleh Hassan. He said, what's the advantages of PD over HD in younger pediatric patients? So he meant in critical ICU, most likely. So Shijan, if you want to answer this.
You see, I think questions like this, like my response would be look in your unit and one, what is your team comfortable with running and what are they used to? I think Prof. Reina has just mentioned that. So overall in South Africa, like PD is used very widely. There's a lot of experience. The advantages of that is like it doesn't suck in as many resources, is easier to initiate. Can be run by your nurses. You don't need to have dialysis technologists on site to make sure your filters aren't clotting, to run your machines, do the flushes, make sure there's no disconnects. So again, it's really tied to what your team is like and what you have available. I think PD can work magnificently if you target it appropriately and prescribe it appropriately. But again, there are some things where hemo would just be much better. Like, for example, a toxin, intermittent hemodialysis would be perfect for that. Whereas PD, you're not going to get that clearance. So the simple answer, as in most things in medicine, is it depends on what your clinical indication is, and I couple that with what runs in your unit and what can your nurses do, because PD is a nurse-run program, so you need to have that buy-in. Thank you, Dr. Khalid.
Thank you.
And
Excellent.
also
Go ahead,
the
Robish.
advancement of the the continuous flow PD, and those are the new advantages coming up. So for inborn error of metabolism, we have a consortium, and some of the people are doing continuous flow PD or a high flow PD and rapid exchanges. So PD is a good modality. The only problem is in setting of sepsis when you have too many things going on. Good example is our HUS, how much that peritoneal membrane will be useful when you have a profound shock or you have a vasoplegic shock, because that spasmodic vasoconstriction can affect, but frequent changes can be. And that's your data from Cape Town, right, Shagan?
Yeah, 100%. So yeah, like Pete Norst, he ran his PhD on looking at continuous PD, and the clearance is magnificent. It really is. And like Prof said, you have to look at what your indications are. Patients that are profoundly shocked, you're not going to perfuse your mesentery, and once you do that, your solid clearance starts dropping. There's a lot of caveats in it, and I think just in the space of this talk, we could have a talk on PD prescriptions alone. It becomes a bit very far-reaching once we start to look into each question specifically.
Absolutely. Go back, use the resources that you have. And actually, as Robish mentioned, we start to learn more and more from Cape Town use of continuous flow PD, especially in hyperammonemia. We don't have actually here, we usually hear, even in the Western countries, they go directly to the CRRT rather than continuous flow. But the basic one, whatever the resources you have, just try to go ahead and utilize it. Here is the good question. Maybe I just flow to all of you, Robish and Imrit and Shijan. So the evidence supporting the use of 2 liters per meter, 1.73 meters square per hour in pediatric CRRT largely came from the adult data normalizing to the body surface area. In the absence of pediatric trial, do you think the body surface area dosing provide more physiological accurate or clinical relevant dosing that rather than will go by ml per kg. And it's a little bit obvious. This is from me, the additive. So I think there is big discrepancy between both. The 2 liters huge will give much higher dose than if you take it ml per kg per hours. So your comments, guys. So maybe we'll go with you, Emrit, initially.
Yeah, I mean, I think part of the rationale there and why the event or why many of us probably still use the body surface area. I mean, probably part of it's we use what we were trained on, but also it's a significance and the degree to which your body surface area varies and changes in that first few years of life as well. So there are people who still use mil per kilo dosing, but maybe change what the range is for neonates, for infants, as they go along as
Yeah,
well.
it's actually it's the big discrepancy occur in as the younger age group, because their body surface area to their weight is little bit in higher side, so it will give little bit higher dose in that one.
And part of that may be that predominantly, at least in a lot of North America, one of the main indications for CRT in neonates is often inborn errors in metabolism as well, right? Where we're using those very high clearances. But I'd be interested to hear what others think as well.
Yeah. What do you think, Shijan, about that? That's one of the big discrepancy people usually ask about using liter per 1.73 or just use it ml per kg. Any
I
input
mean,
from? Yeah, go
Well,
ahead.
we don't use it that often, if I'm honest, in terms of using CRRT. My experience is primarily with peritoneal dialysis. My training was to start on 30 to 35 mils per kilo as a dose, but I mean, there's enough evidence to show you that you can start on lower doses depending on what your indication is or what you're trying to clear. So I normally start at 25 to 30 mils per kilo as a baseline. It's what I was trained with, but I'm Dr. Rayner, and you yourself probably have far more experience than I have.
So I think Amrit said it correctly. Younger kids, I generally go with the body surface area because sometimes 2 liters can be a pretty heavy effluent dose.
Absolutely.
And but for the inborn error of metabolism, I go very high. I go to 45, 50 ml per kilogram per hour. In that case, if you're looking for the inborn error of metabolism, I will use the ml per kilogram dose. But if you're using for sepsis and all, I think if less than 2 years, 3 years, I generally try BSA. The other thing that I have done, which is very good, sometimes I calculate the dose. And if I see with the BSA, I'm getting a lower dose and I need more effluence clearance, then I will go with my dose of 2 liters. So there's no difference, but there is a data that you underprescribe them when you not use their body surface area.
Absolutely. Here is a question, probably you, Robish, for the neonate with hyperammonemia. So he said that few studies suggest it can go up to 8,000 ml
Yes.
per 1.73. And which modality you would like? I know that there is a consensus guideline on hyperammonemia, and you let that work.
So we did it together. We were partner in crime. So
Thank
this
you.
it is that the high dose came out very high. It's 8 liters, which they use for hyperammonia. So you have to understand in burden of metabolism, there are 2 kinds. One is when you have a regeneration rate very high, especially like leucine, lysine, or any amino acid disorders, because they are continuously producing. So your endogenous clearance is not very good. But the other thing is they're all zero kinetics. You can remove them well. It is easy to remove. So what I will see is what I have done most of the time is check your level in 4 hours. If you see your regeneration rate or you are not clearing more than 30%, you escalate dose every 4 hours. But the problem is in our center, the paper that came out from the STU is using 8 liters. I will not be able to do it in my center. I have to get a PNT clearance. So what I do is I go with 35 to 40. And if I don't get, you can always escalate the doses every 4 hours. Born error of metabolism is a nightmare for us because you have to be careful. The ICP is a big issue there. So intracranial pressure you need to watch, and their mortality and morbidity can be very high. They can come after you 10 years later. By the way, Dr. Kriplani and Shajan took care of my son. His ICP was high for 48 hours. He's learning his difficulties. And the
Absolutely.
US, they're waiting for all these things. And I was in a witness for a couple of the cases. They called me and this happened. I said, listen, this is the best we can do. This is standard care. So don't go. 8 is very, very high, 8 liters. I cannot get it done. 35 to 40, 40 to 45. You can get a good clearance. Give us sustain. Even if the ammonia is coming down, run it for a while because they regenerate very fast.
Rebound. Yeah.
Rebound is a tough thing. And nobody knows when they're going to rebound.
And I think from the consensus statement, and you guys correct me if I'm wrong, I think this was one of the cases where there may be more advantageous to do CVVHD or primarily diffusion versus
Yes.
convection, especially
Yes.
when you're using the high clearance rates there.
It's a suggestion. There was no grade of evidence, but yes, because there's zero kinetics, zero order kinetics. So you can remove them faster with diffusion, but sometimes they get into profound shock and cardiovascular instability, those. So we said CVVHD, but there is no data. There's no comparison. It was a suggestion.
Yeah. And if they can tolerate HD also, it will be better. But most of the
Much
time,
better.
the situation, yeah. Actually, just a few hours back, I had a patient with ammonia is 300 plus. So my fellow was prescribing the dialysis on this patient, CRRT in this patient. So the last, probably because of the time, the last question to Amrit, they ask about filtration fraction. Maybe you just give a few comment on that and what is the target.
Yeah, absolutely. So maybe just what I can do is even just pull up the slide because trying to describe the formula is maybe not as helpful because I saw that question in the chat. So I'll just leave it up here. But essentially, you're looking at what's coming out of your filter versus what's going in your filter. So you'll see it written in different ways, but essentially, when we think of all the things that are coming out of our filter, we're pulling off our volume for our pre-blood pump rate, our post-filter rate, and then any additional fluid you're removing from your patient. So everything you're taking out divided by what you're putting in, which is your plasma flow rate. That's your blood flow times 1 minus hematocrit, and your pre-blood pump rate. So what this essentially tells you, it's easy to look at this and just, oh no, what am I looking at? I'm back in high school. But overall, if you are the higher your post-filter rate, the higher your filtration fraction will be, and the higher your pre-blood pump rate, the lower your filtration fraction will be on average. So you want to ideally keep this less than 20 to 25%. We try to shoot for less than 20. So if your filtration fraction is kind of hovering over 20, you're at a higher risk of clotting, and ways to mitigate that would be lowering your post-filter rate, increasing your pre-blood pump rate, and also your dialysate is kind of free in all this. So your dialysate won't affect your filtration fraction.
Excellent. Thank you very much. The good news that the new machines now, they calculate it by itself. So you just look to the monitor, you can find the calculation for the filtration fractions. Thank you very much. There is one question they ask about the website. Yes, the website of the BCRRT Iconic is bcrt.com. You will find all the protocols needed and make your life very easy. bcrrt.com. So thank you very much. I can disclose the attendees, it was over 400, which was that tell you the people are enthusiasm to listen to this important topic. Thank you very much, Professor Amr, for arranging such a nice a form that we are discussing rather than just classical presentation. The mic's to you, Professor Amr.
Thank you so much, Professor Khaled and Professor Robashrina, and our great speaker, Dr. Amrit, Dr. Shigan, and Dr. Reddy. And of course, thank you for the attendees. And by tomorrow, you should all receive the link of the recorded webinar on YouTube, so you can hear it over and over. We'll be in touch also, and we'll send you more links. Everything that we have discussed regarding the AI simulators, apps, we are going to share it with you, the links. And by next week, everyone who attended this webinar should receive the attendance certificate. Thank you again, and we'll see you next month in a different webinar.
Salam. Thank you very much.
Bye.
Bye-bye.